Good afternoon, everyone, and welcome to the first virtual Department of Medicine Grand Round. We're thankful for the Department of Medicine leadership for supporting online education during this unprecedented time. Thank you, Daniela from the Division of Cardiology, for organizing this activity. Few housekeeping points. We will leave 10 minutes for questions toward the end. If you have a question, please use the raise hand function, and then you can unmute when we call you and you can present your question. We'll go ahead and get started. This day in history. In March 24th, 1976, President Ford ordered swine flu shots for all. The virus surfaced in February at Fort Dix, New Jersey, where 19-year-old David Lewis told his drill instructor that he felt tired and weak, although not sick enough to skip a training hike. Lewis was dead within 24 hours. The nation's health officials urged President Ford to authorize a mass inoculation program aimed at reaching every man, woman, and child. And in the picture, you see nurse Clean Spacky administering swine flu injection with an injector gun on the first day of immunization program in New York City. However, the swine flu vaccine was associated with Guillain-Barré syndrome. So the vaccination then was discontinued. And Richard Crouse, the director of the National Institute of Allergy and Infectious Diseases, wrote that the government response to the swine flu outbreak was considered to be too fast, and the response to AIDS epidemic was too slow. And here you see the picture of the US President Gerald Ford receiving his vaccine. On March 26, 1953, Dr. Jonas Salk announces on a national radio show that he has successfully tested a vaccine against poliomyelitis. The virus caused the crippling disease polio. In 1952, an epidemic year for polio, there were 58,000 new cases reported in the United States, and more than 3,000 died from the disease. Dr. Salk was well known for his famous quote, "Hope lies in dreams, in imagination, and in the courage of those who dare to make dreams into reality." March 31st, 1981, Amanda Mohan Chakrabarty, a biochemist, a professor at the University of Illinois, Chicago, patented a new single-cell life form. And he won a patent fight which changed the era of test tube science, and that was in July 1980. The famous Isaac Newton died on March 31st. And in 1665, the plague closed the university where Isaac Newton was attending. So he was forced to work from home for almost 2 years. During the plague, foundation of calculus, and he did most of his novel work. He examined the elements of circular motion and applying his analysis to the moon and the planet later led to the discoveries about gravitation. And the famous Dr. Osler said it is much more important to know what sort of a patient has a disease than what sort of disease a patient has. And while we're living this COVID-19 pandemic, it's important to remember that patients could have other diseases other than COVID-19. He as well said, one of the first duties of the physician is to educate the masses, not to take medicine, soap and water, and common sense are the best disinfectants. With this, I would like to introduce Dr. Chang. Dr. is currently an associate professor of medicine at the Division of Rheumatology. She serves as the chief of rheumatology at the VA. While her research focus was on osteoarthritis, she spent some time at the CDC, and she will talk to us today about epidemiology and COVID-19. Dr. Chang, please share your slides now.
Thanks. Let me see if I can figure out how to do this.
Just share slides.
No.
Let me try this again. Share screen, maybe?
Or the audience, please bear with us. This is the first online grand round. Yes, Tina, from the beginning? Yes.
How is this?
Perfect.
Perfect. Okay. So thank you for tuning in. I am going to try to make this interesting. However, there is a lot of information, as you might well imagine. I'm going to be skipping a lot of slides. If there are questions, please feel free. What I'm going to do is start with some of the epidemiology and background of this pandemic in light of previous pandemics. I'm not going to spend much time on this particular one since we're all getting pretty familiar with the timeline of it. Then I'm going to look at some of the rheumatologic contributions, so to speak, after exploring a little bit about what the COVID-19 virus is. So basic definitions: an epidemic is the occurrence of more cases of disease than expected in a given area or among a specific group of people over a particular period of time, and usually that refers to influenza. An outbreak is basically the same definition, but usually over a limited geographic area. And a pandemic classically refers to a novel influenza, usually influenza A, when it emerges and then which is able to infect people very easily and spread from person to person in an efficient and sustained way. I should add that by definition, novel usually means we do not have a vaccination for it. Again, usually influenza A is the cause of a pandemic. A regular influenza A becomes something that can be novel when usually one of two changes happen. As we know, there are two subtypes of influenza A, the H and the N. And usually what happens is either we get an antigenic shift, which is a major change in the virus itself, or when we get a genetic reassortment. Usually influenza A exchanges genetic information with a non-human virus. I don't need to spend much time on this. Basically, pandemic is what we're living through right now, and nothing is quite enough as expected. I wanted to go through a case study. The case studies in Epi are kind of bigger than a case study in a patient, but the 1918 pandemic, which everyone is talking to, I think you're going to see a lot of parallels between that time and now. That did turn out to be an H1N1 influenza A. It first emerged during World War I, and the spread was worsened by overcrowding and global troop movement, especially our troops, but everyone else's as well. The problem then, as now, there was no vaccine and no real treatment, and there was no pharmaceutical intervention. Ultimately, approximately 500 million, or 1/3 of the world's population, was infected, and at least 50 million deaths occurred worldwide, approximately 675,000 of those in the United States. The mortality was the highest in under 5, over 65, and the 20 to 40 age, you'll see probably because of the war. But I guess it could have been anyway. The highest mortality, there was a very high mortality in healthy people. Basically, the setting was perfect. We entered the war in June of 1917. At that time, we had 375,000 armed forces, and they had established a draft. And with that draft, they established 32 large camps, each with 25 to 55,000 soldiers in it. In March of the following year, there was a flu-like illness that appeared in the camps and in Europe. And then right away in April, after the disease appeared, there was global troop movement, and we had hundreds of thousands of soldiers crossing the ocean by boat monthly. In September of 1918, we had the second wave of flu, so after the summer. This was highly fatal and responsible for most of the deaths. For instance, one of the camps at Camp Devens, based in Massachusetts, alone had 757 deaths with 14,000 cases. By October, there were 195,000 Americans dead of the flu. This looks familiar. A severe nursing shortage. The cities were closing their gathering places. Cold storage was being converted to morgues. And New York City, in the middle of the war, reported a 40% decline in shipyard productivity, largely due to the flu. Just a few pictures. All of these pictures came from the CDC archives. This is a picture outside of Boston where Camp Devens was located, and they've got Red Cross volunteers making masks. Looks kind of familiar also. The historical context was that basically a large majority of the physicians and nurses were in the military service at the time. Due to the shortage, in October, Congress approved $1 million at that time for the U.S. Public Health Service to recruit physicians and nurses. Just some of the things that were being done there. They're wearing masks, they're telling you to keep the windows open. San Francisco, I guess where it's warmer, had an open air police court. Does not look like they're 5 feet apart. We have street sweepers who are also arranged to work as grave diggers in their off hours. This I thought was actually kind of an interesting thought. They had drivers who drove and 40 nurses who could out with them care for 30,000 patients a day in their own homes. That comes out to 75 patients a nurse in a day. In 1918, in November, there was an armistice, and now we had 4.7 million soldiers who all came back by boat to the United States. So at that point, we had a third wave of flu, which didn't go away till the summer, with a lot more deaths. For instance, San Francisco had 101 deaths only in the first 5 days of January. And unprecedented at that time, Boston City Hospital begins to ask for funds to study the flu. In February of 1919, the flu, they think, is almost gone. And in April, President Woodrow Wilson collapses during the peace treaty negotiations at Versailles. And some of the historians think it was because he was weak from the flu, which was still very prevalent in Paris at that time. Sure, this pandemic occurred, we in the United States and around the world started to institute influenza preparedness. And I've just put together a quick timeline because what you'll see is that the results of this made a huge difference in the 2009 pandemic. So basically, they were able to isolate the virus from people. And this was a huge controversy at the time, was it viral or bacterial? In the 40s, we started to get flu vaccinations. They found influenza B, and because of it made a bivalent vaccine, they started making mechanical ventilators. CDC was established and WHO was established. In the 50s, WHO established a global response system for the flu, and the CDC established an influenza branch, which was established specifically for surveillance, epidemiology, and control of the flu. In 1957, this was all tested and probably refined with the H2N2 pandemic, leading to 1.1 million deaths and 116,000 in the States. In the 60s, they started to recommend annual flu vaccines. Amantadine was licensed as an antiviral. There was a connection found between the human flu and the avian flu. And again, at the end of the decade, there was another pandemic, this time H3N2, with 1 million deaths globally and another 100,000 in the States, used mostly in the over 65 flu. In the 1970s was the swine flu, another H1N1 that Dr. Weiss mentioned, with cases of Guillain-Barré syndrome linked possibly to it. In the 80s, CDC starts collecting reports. And in the 90s, we see that Medicare starts to cover the cost of the flu vaccine. We get Rheumatidine. We identify the first avian flu, well, the first identified avian flu with the first case of it in humans. We also find the swine flu. WHO establishes a pandemic framework. And then they also license oseltamivir and remdesivir, which, as you see, hasn't changed a lot in the following, 30 years? In the 2000s, vaccinations increased. We get the flu vax. The government gets a national strategy. They sequence an entire genome of the 1918 flu. And then in 2009, H1N1 comes by, and I'll go into that in more detail. In 2010s, WHO declares an end to the epidemic. My second case study then is the 2009 H1N1 pandemic, which is also an influenza A. This photo is from the CDC archives. Now, contrast this to what's happening now, because in the first 10 days of the 2009 pandemic timeline, after they've established all these measures, we have the first case showing up April 15, and it was detected this time in California. The second, 2 days later, was 130 miles away with no known connections. And these two cases were reported to WHO on the 4th day. On the 21st, the CDC starts working on a vaccine. This is 6 days after the first infection, and they do it because you've got two cases spread apart in distance with no connections. So those of you not familiar, but I think everyone is, first step in making a vaccine is to find a candidate molecule, or so to speak. And so that's what they start to isolate. Then you get, in the 23rd, 8 days later, you have two cases in Texas, and this becomes a multi-state outbreak. And on the 24th, CDC, 9 days later, uploads the complete gene sequence of the new H1N1 virus to a publicly accessible international influenza database. And these are extremely important modifiers here because that didn't happen this time. And then on the 25th, 10 days later, WHO declares a World Health Emergency. The 26th, the US then declares a public health emergency. And I should note, emergency is not the same as a pandemic. But also on the 26th, which is 11 days, the CDC starts to release 25% of the antiviral drugs that are going to be needed to treat influenza virus from the federal stockpile. The 27th, WHO starts to escalate towards a pandemic alert. FDA approves a CDC test, which is, what was it, the 15th? 13 days later, CDC has developed a test to detect this infection, and they start to issue guidelines on closing down schools and other things. WHO on the 29th, this is 2 weeks, brings it from a 4 to a 5, basically saying that it's almost here, guys. And they want all the countries to immediately activate their pandemic plans, be on high alert for unusual outbreaks of influenza-like illness and severe pneumonia. So I really wanted to show this case because I think it shows what happens when something is working right. And I think many times Americans have I've taken the CDC system and other surveillance and flu prevention systems for granted, almost. It's just something that's supposed to work. This flu season peaks in May and June, which is a little worrisome for us, if that's real. The CDC starts to send shipments everywhere for testing kits. They actually go to 14 days instead of 7 for closing down schools. WHO declares the pandemic June 11, and that brings you to a phase 6. In July, we start doubling and tripling. What's important is you start to get oseltamivir resistant flu virus in different countries. In July, April, May, June, July, months later, we're starting to do clinical testing of a vaccination. We find more resistance. The second wave starts in August. I think flu reporting season actually officially is August 30th at the CDC. Oh, yeah, there we go. We are shipping test kits, 250 international laboratories, 140 countries. It's been going on. And this is specifically for, you guys may know, CDC has nothing that's patented and no specific rights to anything. So they are sending these specifically so other countries can make them using their pattern. So not only are they sharing the information, but everybody's kits are going to be equivalent, we think. There are vaccines that are approved by September. We place our orders, we launch a campaign. October, which is 5 months later, I think, 5.5 months later, we've got doses of the flu vaccine being given. The second wave hits, and basically by the next year, the pandemic is done. So even in a well-organized pandemic, it took 1.5 years. So there were differences, right? We had a government policy, CDC did sequencing of the virus, developing, sending test kits, developing a vaccine, monitoring disease spread and strains of the virus. And we might ask what's happened, and I will go into that a little bit. There's also a question whether they were helped because there was maybe some residual in 80-plus-year-olds from the 1918 flu. And of course, it was shorter possibly because of the war not being an issue. I thought this was interesting because the slogan for Corona beer is miles away from ordinary, and I guess that's where we are now. I've gotten newspaper pictures are from the Chinese paper that my father used to subscribe to, the Chicago version of the Worldview. I'm just going to flip through this quickly, and I'm not sure we need to know much, except that the first case was much earlier than people thought. It was on November 17, and it wasn't even recognized at that time, and nobody knows if there was an earlier patient. The one that we all hear about was in December, on December 1. So depending on when you count it, it was either middle of November or the 1st of December, already 2 weeks later, that the first patient was found. This is just a picture showing the empty streets in China right at Chinese New Year, along with a picture of the virus. This I'm going to spend a minute on. Dr. Wen Liang is an ophthalmologist who got recognized posthumously, which is always sort of a bummer. He tried to report those first 7 patients. There was a cluster, and only 2 of them were linked with the seafood market. So there were a lot of rumors flying about, but 5 were not. But he wanted to report them. He reported them on social media, and he was reprimanded, forced to sign something. But anyway, he ended up developing this corona. In January, he got the dry cough, the fever. He was admitted to a hospital. Sadly, his parents also got the coronavirus. So all 3 were admitted at the same time. He tested positive. I don't know. It seems that the negative tests are a recurring theme in the Chinese cases, and then on February 6th, he dies. And the people demanded an apology from the government, which I think this was. Okay, I don't know that I really need to mention all of this, except that CDC is not alerted till December 31, which is 6 days later. You'll remember they got alerted on day 4 of the 2009 vaccine. They issued a level 1 travel watch, which is practice your usual precautions, on January 6th. The scientists in China announced this, which is what, 7 weeks later or so. They post the gene sequencing online on January 10. They finally have established human-to-human transmission January 14, which is 2 months later. And on January 18, this is interesting, somehow the information in China was scrambled, I think, and we've all saw the political issues involved. But basically, in the middle of this, Wuhan holds an annual Chinese New Year banquet with 40,000 people sharing dishes, plates, and everything else. This was, I think they really wanted to do it because this was supposed to be a model community in China. So anyway, after that, things start happening quickly. This is a picture of the hospital that they start to build, and I have better pictures of it. It wasn't until January 31 that the US declares a public health emergency and closes the borders to all foreign nationals, quarantine. So this is 2.5 months after that first case. And this was after a sort of half attempt to evacuate US citizens. After they started, they decided they weren't able to do everybody. Early February, Wuhan is over 10,000 cases. End of February, this virus is now found in tears and conjunctival secretions. And I think rather stunningly, February 21, the US Association of Public Health Laboratories says that we have 3 states capable of testing for coronavirus. December, January, February, 3+ months later, we got 3 states that can do a test. Look at this, same as 1918. And then in March, WHO declares the pandemic. This is Wuhan. I couldn't believe this. They decided to build a hospital. They built 2 hospitals in the span of 10 days, just specifically for coronavirus patients. Look what they do. This is incredible. This is how they broke the ground. This is how they got the supplies in. And this is one of the first patients. So this is wild. Summary to date, as of this morning, we have 785, almost 786,000 cases worldwide with almost 38,000 deaths. There is a large number of patients who have recovered. That should keep us from panicking. We have 500,000+ cases that are active. Note that 95% of them remain mild. 5% are critical, and there's probably a whole bunch more that we don't know about. So it probably is less than 5% that get critical. What's important of this is that depending on what papers you read or articles, you have between a 1% and a 4% death rate. So I guess in some areas in China we're up to 15%, but they blamed on lack of resources. But a large percentage of hospitalized for critical or serious disease are not going to make it. And we should remember that as we try to do our best to save them. We have closed cases, recovered, and dead. I'm not going to go over this except basically to say here's the US. Italy I pulled out because it's of interest these days. And the Diamond Princess, this cruise ship that was anchored off of Japan, had a total of about 3,700 passengers, of which 712 were had cases. We've surpassed China now. This is just comparing the two. I don't need to do that. I think it speaks for itself. What went wrong? Why the difference between 2009 and now? And I think this is going to keep people working on it for a while. However, the first thing that happened was the CDC had a representative embedded in the Chinese CDC. Embedded meaning working in the same place and working together. This representative was fired by the Trump administration in July of 2019. This is from the paper, this is the newspaper, 5 months before the first case, 4 months before the first case. The pandemic response team that was created in 2015 was fired. It was disbanded, and their job was to be responsible for pandemic preparedness. It was disbanded in May of 2018. I think the most important thing that we don't know is by law, a transitioning presidency is required to participate in tabletop simulations of potential emergencies, national emergencies. The tabletop simulation team that came in with President Trump is now 2/3 gone. The simulation is kind of eerie. They faced a major test, rapid global spread of a dangerous virus in cities like London and Seoul, one serious enough that some countries were imposing travel bans. Trump's incoming team learned it was an emerging pandemic, a strain of a novel flu, Health systems are crashing in Asia, overwhelmed by the demand. Health officials warned that this could become the worst flu pandemic since 1918. And then they were told cases were showing up in California and Texas. This is not a movie. It's not history. This was a simulated emergency. And for me, a source of real embarrassment, I think this is the first time the United States was not a leader in the pandemic rescue mission. So lots of things went wrong, more than this, but I think these are big issues. COVID-19 in Illinois, nobody needs to know that. This is one of my favorite cartoons ever. What is coronavirus? So it's got lots of names now. It's often referred to as the 2019 novel coronavirus, and I'll explain why later. COVID-19 stands for coronavirus disease. And this is its real name, and I bolded this because it's a SARS virus, which makes it sound a lot more familiar, right? I think what we need to do and what we need to spread is that this should not be a total panic situation, okay? Everything can be looked at scientifically. So how do we look at this scientifically? After we break down the epi, now we have to look at the virus. So the virus is a particle. It's what they call a spiky ball, which is a small set of RNA surrounded by a sphere of fatty lipid molecules. And this is found to be in the beta lineage of coronavirus, which is different from both SARS and MERS. Do not forget that, like other viruses, this is actually considered a relatively fragile virus. Those things about how long it lives everywhere, others live longer. It doesn't survive long if it's not in a body. Here's the RNA, the spike protein, the lipid membranes. This is how it works, and this is what makes it interesting in a bad way. The spikes that you see here recognize and stick to ACE2, which I have in slides, but we all know this is a protein found on the cell surface, and this is the first step to infection. SARS Classic, which was the original SARS epidemic, had to mutate in order to recognize this ACE2. So I don't know if that implies that our SARS came from it or if it mutated simultaneously the same way, but the spike has two connected halves that are activated when the bridge connecting the halves are separated, because that's when the virus goes into the cell. So in SARS Classic, this separation is difficult to do. However, in our SARS, in COVID-19, this bridge is easily separated by furin, which I'll come back to in a minute. So it sticks a lot better. Our virus sticks a lot better, and that's the problem. That's why person-to-person transmission seems to be so easy. Because what happens is the tighter the bond, the less virus you need to start the infection. Some of the work done and presented by Dong, who I'll talk about a little bit later, is that they think that the amplification of this virus is close to a 3, with regular flu being 1.5. That makes this one extremely infectious. What you should remember, and what patients should know, and that's why they keep saying hand washing, these lipid shells are annihilated by soap. 20 seconds of hand washing. And it's vulnerable to the elements. And so this is the flip side. Everyone cites this as horrible, and yet it's pretty good for viruses. Altogether, there are 7 members of the coronavirus that can and do infect humans. 4 are responsible for 1/3 of our common colds. 2 can result in more severe diseases. And then we've got this one. Coronavirus is very stable. There have been over 100 mutations documented, and none of them have been dominant, which basically means none of them is that important. There's one exception. That there are some viruses from Singapore that have been found to miss a stretch of genes, and that same stretch of genes ended up being eliminated from SARS Classic. Maybe it's easier to eliminate, I don't know. But that depletion is thought to make this a much less virulent virus. I just found some pictures of Asian bats. There's the question of the association, and it does seem that it's associated with these bats. 96% homology with bat coronavirus at the gene level. Only 34% homology with MERS. Just because it's in the news and is very cute. This is pangolin, which is known as your scaly anteater. The tongue is sometimes longer than the whole body, and it lives on termites and larvae. How does this virus attack you? Sorry, I'm talking so fast, but there's a lot to go through here. This is interesting again about SARS. Most respiratory viruses affect either the upper or the lower airway. Usually the upper one spreads more easily, but it's milder. The lower respiratory infections are harder to transmit, but they're more severe. And SARS hits both, or COVID-19, maybe I should just call it SARS-2. COVID-19 infects both. And so the question is, does it spread while it's in your upper airways and then it goes deeper to cause symptoms? So what happens in coronavirus, these spikes, oh, we talked about this. I was coming back to furin. This is what it looks like. It's an enzyme by human cells and it's in many tissues and especially the lungs. What it does is it attacks the ACE2 bearing cells in the airways. The dying cells slough away, they fill the airways with junk, they carry the virus towards the lungs, and then the lungs clog, not with virus, but with dead cells and inflammatory fluid. They're thinking now that this can also affect ACE2 bearing cells in other organs, including the gut and the blood vessels. And then the immune system kicks in, fights inflammation, and brings us to our rheumatological part. What happens? In severe cases, the immune system overreacts and causes problems, which most of you probably have heard of, can lead to a cytokine storm. This cytokine storm is actually what they think is responsible for the deaths in the other pandemics and not necessarily the virus itself. So, signs and symptoms, 2 to 14 days, all of these. It's interesting, you talk about fatigue, but every report I could find talked about exhaustion. That seems to be a buzzword. Dry cough, loss of smell and taste reported last week might be an early symptom. And now they're starting to say diarrhea, which makes sense if it's in the gut. It sounds like it's a pretty bad diarrhea when you get it. Might predict, and this is from a talk, this is Dr. Chang, who is the lead physician for COVID-19 in China. He also was the lead physician for SARS there. And he's in pulmonary and epidemiology. And this was when China only had about, 1,000 cases. There were 10 factors to build a predictive model. And I had a friend who was translating his speech, and I don't have all 10. But they're saying that you have to test regularly for lymphopenia and thrombocytopenia, which seems to occur in 1/3 of patients, and an elevated CRP, also all the other stuff we've heard about. Secondly, CDC is not recommending a chest, okay, here I thought I fixed all my typos. It doesn't recommend a chest x-ray or a CT to diagnose COVID-19. It's still sticking by the viral test as a specific means of diagnosis. They're saying chest x-rays are not specific, and CTs should be used sparingly and reserved for hospitalized or symptomatic patients with specific indications. There is some debate about this in the radiology world, but basically what you're going to see is ground glass, posterior segments, lower lobes, and bilateral. Usually a peripheral or a subpleural distribution. And if you do CT scans, it's present quickly. So the chest x-ray taken from Dr. Garcia, who's the vice president of the Spanish Society of Radiology, shows these little lesions subpleurally. If you wait and you start getting the x-rays later, you start getting septal thickening and what they call a paving pattern. And it's rare to be associated with lymphadenopathy, capitation, or pneumothorax. One patient that was, I'm not sure that I need to go through this one patient. I think of note was when this person was admitted to the hospital, clear lungs, no sounds at all. White count was not up, but the CRP was up. And in fact, I guess you could say the white count and the platelets were on the low side, but they weren't really low. received antibiotics, and actually this patient got better. This is some of the consolidation and subsegmentally that you see on the CAT scan. This is a 53-year-old woman on day 8, and then on day 12 where it's starting to get better. A 40-year-old man with lots of it on day 15. Mechanical ventilation issues. Now, I got this again from Dr. Zong's talk, so I'm not finding this in papers yet. And again, don't forget, they'd only had 1,100 cases then. But basically what they're finding, and I put this up because maybe our unit people are seeing this, but that these patients have difficult breathing, but their frequency and their inspiratory muscle strength are normal. And that, this is the problem. Because apparently, and I'm not a unit person, but apparently once the PaO2 and the FiO2 are increased in the patient who's intubated, it's very difficult to withdraw the sedative. And again, I don't know where this fits in the scheme of things, but at least in his hospital, they were using a mix of hydrogen and oxygen to try to reduce the airway resistance. This is just this electron microscope image, and this is isolated from a US patient. Cytokines, I don't think I need to go through that with this group, but a cytokine storm is when you have an overproduction of immune cells and they're activating compounds, which are cytokines, and which in a flu or another infection is associated with a surge of activated immune cells into the lungs. So briefly, angiotensin, angiotensinogen to angiotensin 1 to 2 to vasoconstriction and fluid retention. This is where your ACE works. It blocks 1 to 2, and it also blocks the bradykinin to the inactive products. This is important. Yeah, I thought this is an interesting cartoon of it, because if you look at this ACE1 to ACE2, so ACE blocks angiotensin, but what it actually is ACE2, you can look at a different way and say ACE2 is actually the COVID-19 receptor that's required for cell entry. And that sort of changes the way you look at things, right? Because now we really need to block it. Cytokine storm produces all of these things, including IL-6. But notice there's a whole bunch of other stuff produced and causes your end organ damage and your capillary leak syndrome. IL-6, just as an aside, this is a picture of it, is an important mediator of fever and the acute phase response. It's produced as a result of innate immunity. What happens is these toll-like receptors, I won't get much heavier than this on the basic science, I promise, are found on macrophages and dendritic cells. And what happens is that your virus activates these toll receptors, and then the toll receptors activate the immune system, and that makes your IL-6. And if you make too much, if you have an overactive immune system, you will get your cytokine storm. There is a differential diagnosis for cytokine storm, and that, again, is rheumatology. We have hemophagocytosic lymphohistiocytosis, that's not rheum, but then you'll also get macrophage activation system syndrome, which is interesting because it's overwhelming inflammation characterized by a cytokine storm. And just for the record, this can be, MAC can be part of, is a subtype of HLH. You get uncontrolled activation and proliferation, you get fevers, you get tired. These apparently you don't get with COVID-19. Treatment for our cytokine storms: high dose steroids, plasmapheresis, IL-1, IL-6, IL-18. Interestingly enough, IL-6 does not grant you full protection against a cytokine storm. So I have to touch on it a little bit because there's stuff coming out, and I have to apologize. At the beginning, last week when I was working on this talk, there was a lot more on the front end of the talk, and now there's a lot more on the back end of the talk. So it's been changing, and so the result is my speaking very rapidly. So non-pharmacologic treatment, testing, well, we know how well that's been working. If you test early, the idea is to isolate people. If you test recovered people later, which they have now developed a test for this in New York City, then, for instance, we could test our healthcare workers, and if we've all been exposed, then nobody's afraid to go take care of anyone. Isolation, social distancing is a concept that came from 1918 and before, and is still the best thing. These are in 1918 when they were isolating people. Philadelphia started late with their isolation, so they had a huge peak. San Francisco relaxed their measures, so they got a double peak. New York actually started early, did it all right, and they had the lowest death rate on the eastern seaboard. And then St. Louis had another problem. They sort of relaxed their social isolation. So when your patients complain, you can explain. Now we have new things in our lives: mass technology, sterilizing, manufacturing, covering with cloth, reuse them for 3 weeks, and then ventilator sharing, which was tried in New York and found not to work. So we're back to social isolation. This one I got from my sister. The quarantines, I thought it was kind of cute. Pharmacotherapy. So far, no medications, but I don't think you should lose hope. There were 121 drugs and natural products that were successfully used against previous coronavirus infections, including SARS. There are 4 pages of them. Yes, steroids, lots of steroids. You can just whiz down. There's a ranitidine, lopinavir, chloroquine, mycophenolic acid, ribavirin, cyclosporin. I mean, they're hitting it both at the virus level and at the cytokine storm level. And I think that's the most important thing to know. And you shouldn't feel out there that there's no help coming, because there's going to be help coming. It's just been slow coming, slower than we expected. 7 drugs right now, potential treatments. And I think probably they haven't had time to test all of them, but we've got, sorry, this is a bad slide. We've got chloroquine, we've got interferon, we've got antivirals, we've got Actemra and Kevzara. This was recently published, quote unquote. I need to warn you all, most of the papers that we're seeing coming out have not been peer reviewed. And this is a pre-proof. And on it, it says we could make changes that could affect the entire outcome of our study yet as we go through and proof it. So please see this as a grain of salt. This was done in France. There were 30, I hope I remember the numbers right, 32 patients in the testing group and 16 patients in a control group in another hospital. They took patients, as long as they tested positive on a nose swab, they were used. So they were not early stage, late stage, nothing, just everybody who had the virus. And I should note that of the original 32 in the case side, 6 of them dropped out, several because of death. What they were trying to show was that after 6 days of hydroxychloroquine, that the number of total number of virus in the nose was decreased, and they think it was significant. However, I need to warn people, hydroxychloroquine, they use 200 milligrams 3 times a day for 6 days, and ultimately people are recommending 10 days. That's a lot of hydroxychloroquine. Many people are not going to be able to tolerate that. Our average dose for our patients are 200 BID starting, and a lot of the recommendation is now going to between 200 and 300 milligrams a day, depending on your body weight. Azithromycin was used for those with pneumonia, but apparently also seems to potentiate the effect of hydrochloroquine. This is really early. It was open label. It was non-randomized. It was using, well, desperation methods. Let's see. There's FDA trial already in progress looking at tocilizumab or Actemra. They're looking at a phase 2 trial in COVID patients, specifically using up to 800 milligrams per dose. Primary outcome is going to be the 1-month mortality rate, and they've got a lot of secondary measures. Just so you know, tocilizumab is a receptor inhibitor for IL-6. So you can make all you want, and it's not going to do you any good. I received this slide from a colleague of mine here at UIC. In our section, Dr. Shiva Shahara, who has been studying IL-6 for quite some time, and I believe she developed this slide. But tocilizumab is a humanized IL-6 inhibitor, and it binds to the receptor. Other drug studies, there is a mushroom study, antioxidants, traditional Chinese medicine, ACE2 inhibitors, remdesivir, lots, hyperimmune plasma, and the competitors, IL-6, which is Kevzara. I wanted to say thank you to my colleagues who have been extremely supportive. And with this, are there any questions?
Thank you so much, Tina. We have a few minutes for questions. If you have a question, please use the raise hand function, and then we'll call you.
No questions. No one here left.
Okay, Jalise cannot find the raised hand. It's under participant, but Jalise, please unmute and ask your question.
Okay, so first of all, this is really a wonderful talk, very enlightening, and I just really want to commend you on giving this in its manner and very informative. So my question is, the drugs that you've outlined, there are two critical phases here. One is before you get the virus, and one is after you get the virus and the ARDS cytokine storm. So do you have a sense from the trials that are going on right now and the different drugs that have been identified, or both by bioinformatic tools and by other methods, are they targeting more preventing the transmission, which would be, for example, ACE2, or are they targeting more once you've developed ARDS, where they target the inflammation and the cytokine storm? And the reason I'm asking this is if you, for example, use anti-inflammatory drugs too early on, if anything, you might be more susceptible to getting the virus.
Anybody has had enough time to really differentiate all of them. And I think there are the three phases. One is the antivirals themselves, right? And then there's the ACE2 inhibitor, which I think people, I mean, I don't know if my colleagues agree with me, but in general, I would start with that because you are correct. The IL-6 inhibitors and other immunosuppressive drugs are very immunosuppressive. And yet, if you've turned that corner, for instance, if it starts to look like macrophage activation syndrome, I think you want to try to get out ahead of it, you know, because once you start that storm, it's not really going to stop on its own. And that's where they might really need our help to pull out. But if you look at the NIH, there's about 10 NIH registered trials now, and there's like one of everything.
Thank you, Tina. I see Dr. Darber. Please unmute.
That was a wonderful talk. I just wondered if you can comment on the sort of cardiac complications, and can we use biomarkers as a way to risk strategy?
Oh boy. Well, I don't know a lot about G, but it looks like anything that has an ACE2 receptor is potentially at risk. There are, if you look at the reports, and again, and most of them are peer reviewed, they're starting to look at cardiac involvement. And I don't think anyone has been looking at I don't know if anyone out there has heard about the biomarkers, but from what I've seen, there's not been a lot of that in the literature.
Thank you. Eric, Simon?
Hi, thank you. So in one of your previous slides on one of the older pandemics, you talked about 25% of the population was needed to achieve herd immunity. Is there any thought as to approximately how much of the population currently would need to be infected or vaccinated before herd immunity would be achieved?
Boy, I don't think it's changed much. I believe it used to always, when I was at CDC, they were saying between 1 and 4, 1 and 8. But I think it may depend on how real the disease is. You know, this one seems to be extremely, I think that will change your herd immunity equation. Just if you look at epidemiologically what you need to do to achieve herd immunity. But I don't have any actual data to answer that question.
Stuart?
Thank you. My question concerns patients who are taking immunosuppressive drugs for such as psoriasis. Should we tell all of these patients to temporarily stop taking their immunosuppressive therapy to decrease their risk of COVID-19?
Well, I'm hardly the authority on that. I have to tell you that as a section, we have this discussion every day. What we've decided that it really depends on a lot on how the patient feels and perhaps their relationship with their physician and how the physician, if you have someone with horrendous psoriasis and then crippling psoriatic arthritis, and if they miss their dose for a week and they start to flare, I personally am going to do that. That's my personal opinion. I'm not sure we're going to do them any favors by making them miserable, decreasing their function and mobility, and perhaps their ability to fight anything should they get it. However, there's a whole group of people who figure, life at any cost is more important. I don't know. I mean, the 1918 pandemic, 1/3 of the world's population ultimately infected. And they had no ability to make a vaccine. Now that we're on top of it, hopefully within, 3 to 6 more months, hopefully we'll have a vaccine, and depending on how crippled or uncrippled our public health system is, we can get it out to people, then that might be different. Then you might be asking your patients, would you want to try to hold off for 6 months and see into you?
Do vaccines even work in people who are taking an immunosuppressant?
Another good question. Well, there is some evidence that yes, they work, but it doesn't always work completely. And some of it seems to depend on the vaccine. Nadira, is there anything else on? I mean, there's just nothing, but they obviously recommend that you take any live vaccines before you start immunosuppressants. But we have our immunosuppressed patients take the flu vax every year, and the data shows that they seem to mount a response. And I believe that they're included now in the high dose vaccine group. So it does do something.
Thank you.
Stuart, I'm happy to do some discussion offline after that. Tina and I are happy to discuss this further. Joanna?
Yes, I just had the question. What about consideration of prophylactic antibiotics? They are recommended for COPD exacerbations, and certainly some of the patients who present with the COVID-19 positive patients with increased cough and fever have underlying COPD. The use of antibiotics seems to be delayed until the time of hospitalization. I'm wondering if in the outpatients there may be some advantage to early prophylactic
I don't think
treatment.
anyone has shown that for sure, but obviously it makes some sense. And in the case where you might prophylax your COPD patient anyway, then you might consider it. But I don't think there's any formal recommendations. What I do think is that the azithromycin have some antiviral effect also. I don't think anyone has the mechanism worked out, and it's very preliminary. So I would have to defer to people in the know to come up with. I think again, it's kind of the physician knowing their patient.
One last question before we conclude. There is a question, any suggestion for patients with rheumatoid arthritis or SLE who had worse risk and or outcome in terms of death? And the other question from Christy is there good evidence that previous exposure leads to immunity?
I'm sorry, the first question was whether...
Any suggestion for patients with rheumatoid arthritis and lupus?
it's my question. It's Elena Berengol's, whether, you know, like for example, they said diabetes is. So for rheumatoid-related diseases, SLE, anything you've seen that they're at higher risk and have worse outcome, i.e. death?
Actually, there are several data banks ongoing in the city and in the country right now trying to collect that data. So far, all across the country seem to be trying to slow down use, decrease dosages, if and when possible, hold the medicines. And again, our fear, of course, is increasing the risk of death. But there are some patients with very severe disease. I was talking with my colleagues yesterday, for instance, I have with rheumatoid arthritis and uveitis. And if we don't treat her, she can't see. So again, you know, and we can only do our best to apprise the patient of the risks. She knows 100% sure if she misses her dose, she's not going to be seen. And we don't know really what her chance of getting infected is if she avoids exposure until we can get it or not. The second question was—
Is there good evidence that previous exposure leads to immunity?
Yeah, there is. There is evidence. There is still the question. People are not sure how long the asymptomatic carrier state lasts, if there are people who are chronic carriers. But in general, it looks like exposure leads to immunity as with other infections.
And I think it's 103 for those of you who would like, but I'd like to answer the last question for Dr. Ignatius Chang. Is there evidence that patients who have been taking hydroxychloroquine reduce COVID-19 during this pandemic? I'm referring to lupus patients who take hydroxychloroquine.
I don't think we have evidence yet. I really don't. The only thing we're all happy about in rheumatology is it looks like in general they are protecting patients' supply of hydroxychloroquine. But don't forget that the treatment dose they were using was more than what we prescribed. And it wasn't to prevent, you know, ultimately it's going to be a finer question than we have data for right now.
And I have to look at this question from Dr. Ascoli. Is this immunity dependent on corona A versus B virus? Christian, if you could unmute and clarify this.
Yeah, I'm lost.
Yeah, so there's two different strains of coronaviruses, right, in question, where you're saying that there is some immunity that develops. You know, the corona A viruses are standard HL63 virus and so on. The corona B viruses being MERS, SARS, and SARS-2. You know, cross immunity.
I'm not sure that anyone has actually been able to find out right now. Pretty much every time it hits an area, anyone who would be investigating is too busy treating to get a lot of data on it. And even if there was a lot of data right now, I'm not sure. But it looks like there are sequences. The one thing that's unusual about this coronavirus strain seems to be that there's an extra little pocket in the system. And so somehow, as that virus gets released from the cell, that it cleaves off those. And I'm not sure, so far, they haven't reported that pocket on any other SARS virus. And so I'm not sure, I guess, how important that is to the entire genome and whether that's going to make a huge difference because it seems to be affecting the way the virus is functioning.
Tina, one very important question here by Travidi. Would a patient on anti-TNF inhibitor have a protection against the cytokine storm?
Well, I suppose theoretically you would say maybe yes. However, first of all, if you're going to think that the person's going to develop symptoms, suppose on day 5 you develop symptoms, and then people have this period, it looks like even a week, where they're just feeling crappy. For sure, in our week injections and even our every other week injections, if you were up for it, probably you would be holding your injection. So, or at least if your physician heard about it, you would be definitely holding your injection. So I don't think you're going to have a lot of as much drug in your system to protect you from the point of cytokine storm. But again, we're collecting data. All of rheumatology is collecting data. I don't think we can fully answer that question.
Well, I hope I did not miss any question. This is the first try of a web-based grand round. Please, if you have a question, otherwise we will conclude, and thank you all for joining us.
Thanks.
Thank you, Dr. Chang, for a great talk.
Thank you. Was
The
great.
session will be recorded, so you'll be able to access it, and we'll be happy to answer related questions at any time. Thank you.